You sent us a pretty dense stack of clinical trial data and research papers this week, and our mission today is to extract the most important insights from them.
Yeah, there's a lot to get through.
We are doing a deep dive into a 12-month phase 3 trial, and it's investigating a treatment combination for endometriosis, specifically elagolix paired with hormonal add-back therapy.
Right, because roughly 1 in 10 reproductive age women who are living with endometriosis, the standard options can feel incredibly bleak.
Mm-hmm.
You are often forced to choose between this debilitating chronic pain or treatments that just carry heavy systemic trade-offs.
So we are looking to see if this specific drug combo can successfully silence the pain without, wrecking the body over the long term.
Exactly.
Let's start with the pain part. Endometriosis is a disease fed by estrogen, and elagolix is a GnRH antagonist, which...
It basically shuts off the body's estrogen production, yeah.
Right. I like to think of it like shutting off the main water valve to your house to stop a severe plumbing leak.
That is a really good analogy. And the clinical results from your sources show that the shutoff valve works exceptionally well.
Oh, yeah.
Yeah, by the 6-month mark, nearly 2/3 of the women taking elagolix with the add-back therapy experience a significant clinical improvement in their menstrual pain.
Wow. 2/3.
Right, and you compare that to less than 1/4 of the women taking a placebo. It also clearly reduced non-menstrual pelvic pain and even fatigue.
Okay, but wait, here is my issue with the whole shutoff valve idea.
Uh-huh.
If you shut off the water, the leak stops, sure. But estrogen isn't just water in this scenario. It's practically the mortar holding the house's foundation together.
Oh, absolutely.
Like, bones totally rely on estrogen to maintain their density. If we shut down a patient's estrogen for an entire year, aren't we just trading pelvic pain for crumbling bones?
Well, you've hit on the exact reason elagolix, taken by itself, is only approved for 6 months of use.
Oh, I see.
The trial data confirms that without intervention, bone mineral density drops rapidly. We are talking about almost a 2.5% decrease in the lumbar spine
Wait, in just half a year?
in just 6 months, yeah.
That sounds terrifying.
Hmm.
So how does this add-back therapy actually fix the foundation without turning the leak back on? Like, if we give these patients estrogen again, shouldn't the endometriosis just flare right back up?
You would think so.
Yeah.
But this comes down to a really elegant mechanism called the estrogen threshold hypothesis.
Okay, what is that?
It turns out different tissues in the human body require completely different amounts of estrogen to function.
Interesting.
Yeah, so endometriosis lesions are greedy. They need really high levels of estrogen to grow and cause pain. But your bones,
They don't need as much.
right, they only need a very low level of estrogen to stay structurally sound.
Ah, so we are aiming for a biological sweet spot.
Exactly.
We lower the overall estrogen enough to starve the endometriosis, but keep it just high enough to maintain the skeleton.
You got it. The add-back therapy provides a highly precise daily dose. It's 1 milligram of estradiol plus 0.5 milligram of norethindrone acetate.
Okay, I know estradiol is the estrogen, but what is that second component doing, the norethindrone acetate?
It's a progestin. In reproductive medicine, whenever you give supplemental estrogen, you always have to pair it with a progestin
Why is that?
to protect the lining of the uterus from overgrowing. So together, this tiny daily dose really does the trick. Over the entire 12-month trial, bone mineral density loss was kept to less than 1%.
Less than 1%. That changes the map completely.
It really does.
But what about the day-to-day experience for the patient? Are they dealing with, like, a laundry list of new side effects from having their hormones synthetically managed like this?
The tolerability outcomes were actually surprisingly stable. The most common adverse events were mostly mild to moderate.
Like what?
Oh, things like hot flushes, nausea, and headaches. And if we look at the dropout rates, about 12% of women left the study due to side effects, which is actually very close to the 10% dropout rate we saw in the placebo group.
Oh, wow. So barely a difference. Looking at this stack of research you sent us, the takeaway is clear. We finally have a viable 12-month non-surgical option that balances powerful pain relief with real bone protection. It starves the disease without starving the bones.
It represents a major step forward in how we can safely manage chronic, estrogen-dependent conditions over a longer horizon.
Which leaves you with a pretty wild thought to chew on.
Yeah.
If medical science can successfully hit pause and synthetically manage a woman's estrogen cycle for years at a time just to treat chronic pain,
Right.
how might widespread use of these threshold therapies fundamentally reshape our understanding of reproductive longevity and aging itself?